Thank you so much for coming to our bi-weekly seminar here, our innovative series seminar. I have a few things to tell regarding our settings here. So online participants, please keep mics muted unless asking a question. Use the chat feature in BlueJeans if you have technical questions. That's for the online participants. Previous presentations are available on our website, DE-CTR.org. Please sign in, everybody, to receive CME credit. We can receive credit online, but use BlueJeans chat to contact Sarah Faye at start of presentation, and Sarah Faye is just right there. Please come in. Next week we don't have any presentation. Then we have a series about observational study, which will start with Pan Wu, our own biostatistician here, observational study overview. And then I think Zugwe is giving us a presentation, and then Pan Wu again, right? Pan. And the full summer schedules for our seminar is available, and please grab a copy and mark your calendars. So we are delighted today to have Mia Papas with us to give us a talk.
Again.
Mia has come a couple of times already, and we absolutely love hearing her talking. She is a faculty also with the CTR, with the ACCEL CTR, and many of us are working with her on several projects within the ACCEL CTR. So Mia is assistant professor in the Behavioral Health and Nutrition Department at University of Delaware. She has a master in epidemiology and biostatistics from University of Massachusetts, and a PhD in epidemiology from Johns Hopkins. She is currently the director of the undergrad minor in public health at University of Delaware. She also has a joint faculty appointment at University of Delaware in the Applied Economics and Statistics Department and the College of Agriculture and Natural Resources. And she's also an adjunct professor in AP and Biostat at Drexel. She has a very long list of publications. She has many grants, and she's also on the board of various organizations such as the Delaware Family Voices and the Food Bank of Delaware. So, very important person.
Thank you
so much. We are delighted to have you.
Thank you. I'm very excited to be here. So part of my research focuses on understanding health disparities in populations, especially around obesity. And so today I'm going to talk to you a little bit about health disparities when it comes to individuals with disabilities in populations. So the outline for today is, first I'm going to just kind of go over, we all sort of know obesity is a problem. I'm going to talk a little bit about obesity among children and adolescents with disabilities and sort of what that looks like, what the prevalence looks like. Then I'm going to describe some preliminary results that we have looking at behavioral risk factors that have been associated with obesity among adolescents with disabilities. And finally, I'm going to kind of throw some information out there to get you thinking about avenues for future research. So we're all aware of the crisis of childhood obesity that exists in our country and throughout the world. And although there's been sort of some debate as to whether or not rates are continuing to increase or whether we sort of have seen a plateau recently, overall rates remain high, and we have about 18% of our children and adolescents that continue to be obese in 2012. And we know when we talk about obesity, that's sort of part of the reason why we're so concerned about obesity is that we also see these rapid increases in cholesterol levels, in blood pressure, and this is a change, an increase in both systolic and diastolic blood pressure that we see on a population level as obesity rates have increased here from 11% to 6%. We see this increase in blood pressure and other cardiovascular risk factors. So there's no doubt that obesity among children is a major problem that we're all sort of dealing with. There are certain subgroups that we know of to be at risk for obesity and for the development of obesity. So these data present the prevalence of obesity by race, ethnicity, and I think we're all sort of aware that there is this health disparity when it comes to race ethnicity, in that, for boys, we see Mexican American boys twice as likely to be obese, non-Hispanic blacks, and then Hispanic whites in that order. And we see it for both boys and girls, that there's this race ethnic disparity in obesity. And then what I sort of like to talk about today is what is the disparity in obesity for those with disabilities. And it's quite timely because in February, Gloria Cron from the CDC produced a report that was discussing the fact that persons with disabilities is an unrecognized disparity population. Right? And so bringing to light, looking at health disparities among kids with disabilities is something we all should be concerned about. So the first thing when we talk about the prevalence of disability is that we have to think about the definition of what disability is. And so what I'm going to talk about and show you is a very general definition of disability. There are, I think, 21 different definitions of disability, depending on if you're looking at type, if you're including chronic illness and special health care needs sort of within that. Depending on the type and your disability definition, the prevalence of disability among children and adolescents ranges from 6% to up to 20% of kids defined as having some type of disability. And in August of last year, there was a report in Pediatrics that came out that estimated, using a big national data set, using data from the National Health Interview Survey, that about 10% of kids had some sort of disability or special health care need. And from that report, sort of more interesting thing was they tracked the prevalence of disability over a decade and found a 16% increase in the prevalence of disability, no matter how you define it over that time period. Right? So we have about 10% of our kids, and we see this 16% increase over time. Right? And the projection is that this increase is going to continue. And the American Academy of Pediatrics just put out a news report that said that they see a disparity in the type of disability. So physical disabilities have actually been kind of consistent, but the increase has actually been in more mental, emotional, and learning disabilities.
Yeah. So could the increase be related to a change in definition?
So what they did was they used the same definition and back applied it to sort of previous years. So that the disparity that you do see, which may be due to definition, was kind of taken care of. So they applied the same definition that included functional limitation and chronic disease within that. Okay, and so what we know of when we look at obesity, I think right now, it's sort of common knowledge that there is this disparity in the prevalence of obesity when we look at kids with disability. And these are data from the National Health and Nutrition Examination Survey, looking at children between the ages of 2 and 17 years. And we see that children with disabilities they have about a 38% higher prevalence of obesity compared to children without disabilities. And we see this disparity in obesity within the population of kids with disabilities, both across gender lines and race ethnic lines. So you see the increase in the prevalence of obesity for boys and girls. So here's the overall rate, and you see the increase for those. This is looking at just mobility limitations for those with girls and boys. And you see sort of an increase in obesity among kids with disabilities across race ethnic groups. Right? So no matter what race ethnic group you look in, you still see this increase in obesity for kids with disabilities. So it exists, right? You have a higher prevalence of obesity. So what are the consequences, right? And so for children with disabilities, they have this underlying chronic health condition or some underlying condition that can be made worse by also overlying obesity on top of that. And so when we think about sort of how obesity impacts this population, there's some research out there to kind of bring light to the fact that, we think about things like bullying, and that we know kids who are overweight or obese are targets of bullying, and then we also know that children with disabilities are targets of bullying. So you sort of put the two together and you have this cumulative impact of things like bullying. There was a report in 2005 that actually showed that health-related quality of life for kids with developmental disabilities, there were progressive declines in health-related quality of life as their BMI increased, right, within this same population. And obesity can interfere with independence among kids and adolescents with disabilities. So I just want to kind of go through sort of what that means. And so for a child with a disability that may be struggling with becoming independent, obesity can reduce mobility, right? So it can cause braces and prosthesis to be outgrown. You see the need for different kinds of braces and maybe eventually wheelchairs with wider wheelbases, which are difficult to get around. And it interferes with self-care, right? So dressing oneself becomes more difficult. It's harder to tie your shoes. It's harder to do all of those sort of daily living functions that we sort of take for granted. That with a kid with a disability, you work on those things and then you overlay obesity on top of that, and it becomes more of a challenge to take care of oneself. Obesity also interferes with the chronic health condition, so not just the underlying condition that causes that may be part of the disability, but you see cardiovascular disease risk factors occurring at earlier ages. So this was a study looking at kids with spinal cord injuries, and at much earlier ages you saw an increase in insulin resistance, abnormal glucose, high LDL cholesterol levels, low HDL cholesterol levels. So obesity is a problem within this community. There's sort of four theories as to why obesity does sort of increase or is higher prevalence within kids with disabilities. One has to do with differences in body composition, right? And so a lot of work in this area has been done with kids with cerebral palsy, which looks at the difference in sort of lean muscle mass versus fat mass. You see an increase in fat mass maybe leading to the obesity. There's lots of medications that kids are on that increase appetite that may lead to the obesity. And then there's behavioral indicators. So things like parents have been found to be over-permissive when it comes to diet and food and foods that their children might have access to, and over-restrictive when it comes to exercise or physical activity. In addition, there's a lack of physical activity within this population. So I'm just going to kind of touch upon physical activity real fast. So physical activity has been sort of a focus recently, and there was a summit in DC in the fall looking at really focusing on the lack of physical activity that exists for kids with disabilities. Right? We know that youth with disabilities are denied opportunities to participate both in school-based or after-school-based physical activity programs, that there are accommodations that are necessary that people might not be aware of or aren't readily available. And many school-based obesity interventions, so the interventions that we do not address the physical and nutritional concerns that might be associated with particular disabilities. Right. And so in October, I had the chance to attend a research forum that was in Washington, D.C., and it was focused on improving the health and fitness of Americans with disabilities. It was talking about children with disabilities. And there are different programs out there that are being promoted, right, for kids with disabilities, but the uptake of those programs across communities is very low. And so this forum sort of brought experts around the country together to talk about sort of this issue and how we deal as a nation with the issue of increasing physical activity among adults and children with disabilities. So to address this research gap, kind of figure out what's going on, we did a study. So I did a study with some colleagues, Dr. Jim Rimmer, who is at the Lakeshore Foundation in Alabama, and Dr. Jillian Trabolsi, who's a nutritionist at the University of Delaware with me. So we did a study because we found there's not really good national data on physical activity levels and dietary behaviors among youth with disabilities. So we know obesity is a problem. What do the dietary intakes look like? What does physical activity look like in this population? So we investigated associations among demographics, diet, physical activity, and obesity in a large population sample of adolescents in the U.S. and looked at differences between adolescents with and without disabilities. Our study population was the 2011 Youth Risk Behavior Surveillance Survey. So this is a population-based survey of high school children, the grades between 9 through 12. And we used data that came from 4 states, including Delaware, North Carolina, North Dakota, and Rhode Island. And we chose these 4 states because the disability questions in the YRBS are an optional module. So they're not asked, like race, ethnicity, and gender are asked of all children. The disability questions are still optional. So they're only asked if a state decides to ask those questions. The disability status question, where there were 2 questions within the survey. So the first question was, do you have any physical disabilities or long-term health problems, where long-term meant 6 months or more, and the teens could respond yes or no. And then, do you have any long-term emotional problems or learning disabilities? Long-term, again, meaning 6 months or more, yes or no. And we counted someone as having a disability if they said yes to either or both questions. Our disability definition. Obesity status was self-reported. This was self-reported weight and height. And we used sex and age-specific body mass index percentiles computed based on reference data from the 2000 CDC growth tables. And we defined obesity as having a body mass index greater than or equal to the 95th percentile. We looked at risk factors in 4 major categories. So we looked at demographic characteristics that may differ between kids with and without disability, physical activity, dietary intakes, and then weight loss behaviors. The analytic strategy we used to examine these data were, we used some descriptive and bivariate statistics just to look at the prevalence, the difference in the prevalence of risk factors. And then we used some multivariate logistic regression models to compute associations between risk factors and obesity and examined effect modification by disability. So we were looking, what's the prevalence of these factors? Does it differ by disability status? Can we look at risk factors that we know are associated with obesity, and do we see that the associations between these known risk factors and obesity, do they differ in kids with and without disability? We accounted for the complex sampling design that's used because this is a population-based. So this is the demographic characteristics of our population. So we had 22% of kids reporting a disability, which is a little bit higher than that 10% that was found using the National Health Interview Survey data. So that's about 1 in 5 kids reporting some type of disability using this broad definition. And others have found, looking just in Delaware, that this is consistent with Delaware rates. And there were no differences across the states, so we combined all the states. 50%, so about half the sample was female. About half the sample was 9th and 10th grade, the other half 11th, 12th grade. The majority were between 15 and 17 years of age. So here's your 15, 16, and 17-year-olds. 63% were white, 20% black, and then 10% of Hispanic or Latino descent. There were no differences in demographic characteristics by disability status, except for one. Those with a disability were slightly older. So 64% were above the age of 16 versus 61% with those without a disability, slightly older. And so the first thing we looked at is, do we see the same disparity in the prevalence of obesity by disability status in this population? And so we did. So adolescents with disabilities were more likely to be obese, so 16% compared to 10%, so about a 60% increase in the prevalence of obesity. So sort of confirming what we expected to find. And then we sort of asked those questions, okay, what does physical activity look like for kids with and without disabilities? And so what we found here was that if you ask kids how many days per week were they physically active for at least 60 minutes, right? So how many days per week were you physically active for at least 60 minutes? 20% of kids with a disability, right, said 0 days per week compared to 13%. And so you see this disparity right there in the prevalence of being physically active, right? And you see kind of a dose-response effect in that kids with 52% of kids without a disability are saying that they're physically active 60 minutes or more per day for more than 5 days a week, which is pretty good, right? Where only 38% of kids with a disability are physically active. And when we looked at dietary intakes, the YRBS asks, a few questions on dietary intakes. So they ask, how many times did you consume each of these items in the past 7 days? And so this is consumption of this item at least once in the past 7 days. So we see that, over 75% of kids are eating a vegetable at least once in the past 7 days, a green salad, a fruit juice, 100% fruit juice. And these are statistically significant differences. So there's a slight difference in that kids with disabilities are less likely to report all of these sort of eating all of these healthy, what we would define as healthy dietary factors. And then we asked about perceptions of weight. So we were really interested in kids with disabilities. Do they perceive themselves to be overweight? Are they doing something about it? So overall, slightly less than half of adolescents were actively trying to lose weight. Right? So 45% of all teenagers in this group were actively trying to lose weight. And the kids with disabilities were about 40% more likely to be trying to lose weight than kids without. Right? So they're overweight, they have less physical activity, they're not sort of eating as well, they perceive themselves to be overweight, and they're trying to do something about it. Right? They're trying to lose weight. And so we thought, all right, well, they're trying to lose weight, but they're not being more active. Their diet sort of looks the same. What are they doing? And so that led us to kind of look at unhealthy weight loss behaviors. And this we were somewhat shocked at the percentage of kids with disabilities who were really participating in these unhealthy weight loss behaviors. Right? And so this asked, in the past 30 days, have you participated in each of these behaviors to lose weight? Right? So it's vomiting or taking laxatives, and kids with disabilities were 4 times more likely to say that they were taking laxatives or vomiting to lose weight in the past 30 days. They were more likely to take diet pills or powders or liquids, and also to fast within the past 24 hours. Right? So about 2.5 times more likely to fast within the past 24 hours. And 4% of the population of kids with disabilities were doing all 3 of these things in the past 30 days, compared to less than 1% of kids without. And so this has gotten some national attention, and people are sort of really interested now in, how do we look at this and say, all right, our kids with disabilities are participating in these unhealthy weight loss behaviors at a greater rate than kids without, and is this because they don't have those other opportunities, the physical activity opportunities? Maybe they're restricted in what they can eat or not eat, or what they have access to, and they might be participating in these behaviors at a greater rate. And then finally we said, all right, well, let's look at the predictors of obesity in general, and do those predictors differ among kids with and without disabilities? So we looked at sort of typical predictors of obesity. So it was true that if you were physically active more than 60 minutes, 5 out of 7 days, you had a reduced odds of being obese. If you were sedentary, so 2 hours of television watching per day, 2 hours of video games per day, increased your odds of obesity. And then those that were participating in these unhealthy weight loss behaviors were also more likely to be obese. All models here were adjusted for gender and race. And And then we tried to see, okay, are these behaviors different in those with and without disability? Do you see a different risk profile for obesity in those with and without disabilities? And what we found was disability status did not modify the association between physical activity, diet, and these unhealthy weight loss behaviors, right? So the associations were constant for those with and without disabilities. The same risk factors are there for obesity among these two groups, and kids with disabilities just have a higher prevalence of all of these risk factors. So in conclusion, so the adolescents with disabilities had a higher prevalence of obesity, which coincided with the decreased prevalence of physical activity and worse dietary habits and these unhealthy weight loss behaviors. And so in thinking about successful obesity interventions, we really need to think about and target these weight control behaviors and what teens with disabilities are doing to try to control their weight. And understand the barriers to healthier diets and to physical activity participation. And sort of avenues for next step, what we hope to do within these data is really to explore differences by disability type. And so we want to investigate, okay, maybe it's the kids with physical disabilities versus the emotional learning disabilities, because they might be limited in physical activity opportunities, or is that where you see an increase in these unhealthy weight loss behaviors? Or is it across both disability types? And we hope to explore associations between physical activity and unhealthy weight loss behaviors. And what we have now at the University of Delaware that sort of has come out of this is a public health research lab that is new, and we've engaged our students in using secondary data sets like the YRBS data to explore questions of health disparities in populations. And so we have new opportunities available for students and other collaborators that may be interested in using secondary data sets to ask questions about disparities in populations. I'm excited. And so avenues for future research to sort of think about, okay, what should we sort of be focusing on next? Some of the criticism with this is the measurement of weight and height, and how many kids are self-reporting accurately their weight and height, and does that differ if you have a disability versus not? And so what does the measurement of obesity in children and adolescents with disabilities look like? Can we use these data to examine types or definitions of disabilities? And there's some in the adult population with the BRFSS data. The latest data collection actually asked 6 questions that would allow someone to look at type of disability and sort of narrow down different types of disability. And we're hoping that the YRBS also adopts a more refined definition of disability. The 6 questions come from the American Community Survey, deal with different types of disabilities. And then finally, we need to think about the inclusion of children with disabilities in our health promotion programs. And so we did this little, a quick kind of investigation into how many grants out there, how many funded projects out there in childhood obesity are actually focusing on kids with disabilities. And so this was from 2010. There were 160 total grants, 158 that were looking at youth in general, and only 2 that were really focusing on youth with disabilities. And so this is a population that we need to either start studying or start to include within our larger studies of looking at youth in general. And there was this paper in 2014 by my colleague Jim Rimmer, and so he talks a lot about sort of adapting our evidence-based programs, right? So are we going to have, programs that are specifically designed for kids with disabilities, or can we take the programs that already exist and adapt them and evaluate how well they work for all kids, including kids with disabilities? So there's this sort of exciting work, and it's being adopted in Alabama and in Florida. And there are programs that are using this framework that basically, it's called the GRAIDS Framework, and it takes the guidelines and the recommendations for all kids and then adapts them to include disability within that, and then implements those programs and see how well they work. Okay, so I'm just going to sort of stop there, and I thought maybe we could, if there are questions, or we could talk about anything that I presented, disability, disparities, our public health research group, and how we move forward in health promotion in our state and thinking about kids with disabilities. Yeah.
So it's fantastic as always. So, you know, we now recognize that children with disabilities are at increased risk for obesity.
Yeah.
I think this is true of adults as well with disabilities, that they're at increased risk for obesity. So I just wonder your thoughts, since prevention of obesity in the first place is going to work better than trying to fix it after children are already obese. Where do you see the opportunities to intervene early and prevent obesity?
Great, it's a great question. Thanks. So, you know, just like in kids, in typically developing kids, I think we have to start early, right? And you're sort of thinking about early intervention and those first 1,000 days and sort of birth to 3, and thinking about, you know, opportunities for physical activity. So kids with disabilities, typically, if we think about the state of Delaware, a kid with a disability, they're sort of diagnosed, they enter into a system. And so there's a system, Child Development Watch, or that child now becomes a part of. And so trying to infuse health promotion programs or wellness, ideas about wellness within that early intervention system that we have for kids. So there are models out there. Easter Seals, for example, uses what they call a transdisciplinary model of therapy, where you might have a kid with a language issue that comes in for speech therapy, and with their speech therapy has physical therapy, right? Or has the ability to run around and exercise, or, you know, in an adaptive way, and then also some occupational therapy around that. So you're dealing with fine motor, gross motor, language, all at the same time, and infusing that, and then teaching parents how to do that at home. Because I think parents are really going to be key here in providing those opportunities for kids, and the community having those opportunities where you can bring. Other questions? Yeah.
So you mentioned in your presentation that 22% of the kids who were asked questions
Yes.
Answered with disability. And out of this 22%, how many were the emotion? What was the percent of emotional and the percent of physical disability?
Great. So of the 22%, 60% were emotional learning, and 40% were physical disability. And the one caveat with the YRBS is that you have to be in a mainstream classroom in order to participate, and you have to be able to participate without accommodation. Right. So the YRBS survey has just kind of like a sort of tip of the iceberg of all disability, because you have to participate without accommodation. So your severe intellectual disability would not be in this. And you have to be in the sort of in a mainstream setting, and that's across most states. It's across the board. The majority, there's about half and half, but a little bit more that were the emotional learning. And actually, the ACCEL, one of the ACCEL projects is looking at the youth tobacco survey and trying to see, can we develop a plan, right, an accommodation plan, so that we can include more kids with disabilities in these population-based. We're going to do it for tobacco, and hopefully back it up and do it for the YRBS.
Do you find that kids with emotional and learning disabilities are diagnosed later than physical disabilities, which would maybe cause, you know, that early stage intervention, cause issues with that? And like, how do you see, if that's a factor, how do you see kind of like preventing that?
Sure. So I don't have the numbers off the top of my head, but I'm sure that you're probably correct in that it's easier to identify a kid with a mobility disability, especially if it's congenital, right, than it is an emotional or learning disability that's going to be diagnosed much later when that child starts interacting or talking, and then you see those delays. And so that's why we need sort of a continuation of care sort of across the continuum. So you need that early intervention, that then when that child enters into the school system, right, the schools, that they have a great opportunity to provide adapted opportunities or opportunities for physical education, physical activity for all kids. There's a program in Washington, D.C. There's a school system there that has decided not only, so it's a high school that has competitive sports, but also has adapted an inclusive sports team. So I'm I'm an athlete in my high school and I want to participate in competitive sports, but the school district has also decided to have adaptive sports. So it's typical kids and kids with any kind of disability on the same team. So that's a school district that is working towards trying to increase physical activity. If they could do that, at a younger age, that'd be great. In Miami-Dade County, they're sort of leading the nation in adaptive physical education in their school system. So the public school system there has a K through 12 adaptive physical education program. They've got kids surfing, in wheelchairs. They have a wheelchair basketball league that they do in the school system. They've got kids rowing, and they have adaptive equipment for kids sort of within the school. So as soon as that child is diagnosed, the other issue that comes with a kid with a learning or emotional disability is that they're going to spend a lot of time in therapy. Right? And maybe after school, instead of running around and playing, they're stuck in their 2 hours of therapy sort of every day, 3 days a week, right? And then they're tired and they're not going to want to do that. And so some of these models of how you infuse physical activity into the therapeutic session. Yeah.
You mentioned that in the future, maybe we should have better measurements of obesity.
Yes.
So because the body weight does not tell you everything, right? Muscle weight and lean mass weight will count. So can you speculate, what kind of approach that is cost effective and also give a better way to describe obesity? We know that fat accumulated here will be different, with, different, yeah. So
that's a great question, and sort of one of the challenges I think that we sort of deal with both in typically developing kids and in kids with disability, right? Like, what is the most cost-effective way to measure what it is we want to measure, right? We can't do DEXA scans on everyone, right? So what we have is weight and height, and self-reported or measured. So maybe, within these surveys, we can think about measured weight and height beyond self-reported weight and height, providing the right tools to measure weight, the right kind of adapted scales to measure weight more accurately, kids maybe with physical disability. A waist circumference, I think that right now there's a lot of research being done in kids with CP and looking at sarcopenic obesity, right? Mm-hmm. And say maybe using some of those measurements that are used.
How do they do that?
Other populations.
How do they do that?
They have different ways of sort of measuring.
Does it use
the calipers?
Oh.
They use waist circumferences. They do DEXA scans on kids, and so thinking about maybe from that literature how we can use some of those tools. But right now the best thing we have is our weight and height measurements. We can get better at being able to measure weight and height in kids with disabilities.
I just wonder whether people.
It's a challenge.
Yeah, whether people have thought about measure the apparent density of a body. For example, here, look at the people. You have this weight, and then you get into the tooth bath, and then you can find out your volume, and then you can get the density. Yeah. We know that fat is less than muscle.
They have a bod pod at CHOP actually that they had been using, but they just decided to get rid of it because they found that it wasn't feasible for kids with disabilities sort of be in that. So they're sort of challenged too as to like what are the best. But I think it's an avenue that's ripe for research and kind of understanding what are the best methods and how to measure obesity in the population.
There's some bioimpedance devices too that supposedly measure body composition, but there's a lot
not
of
very accurate.
Not
they
very
might not be
well.
accurate.
Yeah,
That's what I was
yeah.
going to say.
Yeah, my daughter's high school tried them on, and then the results is just everywhere.
Yeah. And if you have some kind of cardiac condition, if you have chronic health issues, those things are not necessarily appropriate for bioelectrical impedance.
May I ask you a question regarding to your population?
Yes.
From fourth stage, your students, the sample is 7,000 to 8,000,
Yeah.
right?
Right.
So did you have to exclude a lot of the survey because of incomplete data? Or, I see you pull 3 major races,
Yeah.
right? So, for example, Asian and the Pacific Islanders, I bet because they're so few. So few. Okay.
But we didn't exclude them. They were in the data set.
Uh-huh.
I just didn't report on that because there were so few of them. Those were the 3 sort of major race ethnic groups. We excluded about 12% of our sample for missing data. So the 9,975 is after excluding 12% of the entire sample. Okay. And had missing data across our major research.
I'm curious how the Asians do. Are they closer to white or Mexican or black?
I think it was less than like 2% of it. But I could definitely look at that.
We also can see differences between South Asians and East Asians.
No,
That's a whole nother very complicated.
So you said that the risk factors were the same in non-disabled and disabled children.
Yes.
And obviously the risk factor for non-healthy behaviors of losing weight are. So are there any, and it's the same for disabled and non-disabled children.
Right.
Are there any programs that are addressing this issue right now? Or?
That's a good question. So not that I know of specifically for kids with disabilities, like in this age group. There are general programs, for unhealthy weight loss behavior, but not specifically for talk about sort of the extra challenge that a child with a disability. And it's a good place for physicians. Kids with disabilities kind of connect with our healthcare system all the time, right, because of the disability, and that's a nice kind of focus that maybe physicians could use to talk about weight and these unhealthy weight loss behaviors. But not new programs that I know.
Question, and this is a question that we've been talking about a bit is when does a difference become a disparity? So when we start looking at our data, and in your data there's not anything that's even borderline, but when does something that's just different become a disparity? Because a disparity is really conceptually different, just a difference between groups. So how did you deal with that?
So that's a great question. So when I think about disparity, I think we kind of focus on disparity versus difference. A disparity really occurs when that difference is due to some preventable factor, right? There's something, so you expect to find differences because kids with disability have some underlying condition, right? You expect to sort of see these differences. But when the difference is due to something that's not the condition itself, but something that's more preventable or modifiable, that's when a difference, I think, becomes a disparity. I don't know if there's an exact number, like, oh, it's 1%, now it's 20%, so now you have a disparity versus a difference. I think it has to do more with the ability to prevent whatever it is that you're.
But it would be something statistically significant.
Well, we found, statistically significant differences. We have a big sample. In a small sample, you might see a difference that's not statistically significant, it might still be something that may be a disparity. Yeah.
I have just suddenly thought another question. For here, focus on the physical activities.
Okay.
Yeah, because you want them to get
Right.
the sweating and do things.
Yep.
How about release their stress level? I assume those kids with disability usually they are very anxious or not very happy. So are there any biomarkers to indicate those kids are usually in a higher level of stress? And whether some relaxation, such yoga or meditation, because that can fit their condition better, and you can address this through, modulating. I know younger kids cannot do that, but the teenager or teens, they can. I don't know whether
we haven't looked at it yet, but in our group, we have looked at bullying and suicide ideation, which is also increased in kids with disabilities. And we see sexual violence and physical violence increased in kids with disabilities. We could look at sort of mental health, the mental health states in these kids. I'm sure you're going to see a disparity. I know of there's one program in Delaware that I know of called Free Frog Yoga, and I've been trying to kind of engage with the instructor to see if we can do some evaluations. So she does yoga with kids with chronic health conditions and disabilities to see, is that having an impact on health-related quality of life, mental health conditions. There was that one study that found as BMI goes up, health-related.
Yeah, even some medication, the breathing technique.
Yeah.
It helps adults, but
right.
maybe also
helping kids.
So I noticed there was reporting on when kids ate well, when they had, vegetables and fruits and things as sorts of markers of good eating. I didn't notice any questions or responses on eating poorly, soft drinks, desserts, fast foods, snacking between meals. And I was curious if there's a reason for that.
So sure. So the YRBS doesn't ask those questions. So they ask about soda intake, and soda intake was the same in both kids with and without disabilities, and most kids were drinking, at least one soda per week. But they don't ask about fast food intake, and it would be great to kind of have a study. So we're writing a grant right now to get a more in-depth understanding of dietary intakes in kids with disabilities and sort of what their full diets. Yeah, but that's great.
So does the YRBS have any questions to the student on their parents' activity levels or modeling from parents on diet? Just curious, I don't even know if it does, but that'd be, I think a lot of the interests to drive they see there.
Yeah, I think that would be
modeling.
great to look at parenting stress. There's a researcher, Chris Modolesky, who works with kids with CP at the University of Delaware, and so we've been kind of talking about, he's got these kids with CP, and he's looking at sort of obesity markers, and now that you've got the parents, can we do something to ask parents about their dietary habits, their stress levels, their physical activity habits, and how having a child with a disability also interferes with their ability. That'd be great.
Yeah.
Great.
Thank you so much.